prescribing, we're literally trending in the United Kingdom, and we've actually catapulted to #1 on the politics. So that is really great. And I think it just demonstrates that social prescribing is something that unites people. So everyone is championing this and tweeting because they feel that this is society. And I think what we're doing today and the report launch is then demonstrating that. So it's something that is owned by everybody. And we can see that even from the scoping work that Community Catalyst has done and Sean has mentioned, you can actually see that we had police, we had housing. So it's not something that is just owned by a particular sector. It's something that does unite everybody. And we can see that demonstrated today with the trend that we're getting. So I think within that kind of like spirit, demonstrates the fact that we need to continue doing that and not actually be too precious about what each other is doing, but looking at how we can bring everyone together, and it should continue to remain that way. So we, as part of our bit of work, was to try to build on the work that Community Catalyst has done, the scoping exercise they did with in York and Wakefield. And again, this wouldn't have been possible without a strong leadership and having Anna and Joe supporting that. So what we did was that we held virtual events in both York and Wakefield. We wanted to understand how the various link worker models or similar models work together, how they complement one another, what sort of barriers do they face, and what are the suggestions, because we don't just want to, we want people to have solutions to the problems that matter to them. So we wanted to make sure that those that were on board are able to inform the recommendations that we then make. So that's what we did. And I'm just going to just summarize what some of the things that we found. So in Yock, we found that what was very common was that relationships were built on appreciation of the strengths of each model. So each model had its own strength from the point of view that people lead complex lives. So you can't just have one solution to everything. And in order to deliver holistic support to people, there needed to be an appreciation that each of these models, because sometimes in terms of collaboration, we sometimes come from the point of view of, trying to portray what we can give, or coming from the point of view of the funding being the initial barrier. But they actually appreciated that each of these models actually have strengths. And I suppose this is what social prescribing is about. It's about the strengths of the individual and the strengths of the communities. And it was good to see that that's what they felt was common amongst them. And they all had a person-centered approach focus. So they knew that they needed to focus on the needs of the person, and that enabled them to work together. There was a willingness to collaborate in a strong partnership, and there was an impressive clarity of the roles and the boundaries and crossover and communication. So of course, there were a few challenges that were identified, things in terms of not complete clarity of the roles and competition. You expect that to be one of the things that do come up, but nevertheless, overall, the models, we found that they were working together, complementing one another, because they realized that in order to deliver person-centered approaches, they needed to build on the strengths of each of the models. Some of the enablers included effective leadership. Of course, you need leadership. So Joe's a very effective leader and, took ownership of this and helping to bring people together. And it was quite impressive to know that they do have a practitioners forum, because if we're not talking to one another, how do you even know what the left hand and the right hand is doing? So I think it was a good thing that the various models, those that we are focusing in, either has got a place-based approach, or where their clientele or the different groups that they are supporting had an opportunity to at least talk with one another. And if it's something that we had across the country, I think that would be a massive progress. There were suggestions in terms of improving the communication by having a directory of, all of these practitioners, so that it just helps in terms of navigation and directing support, so that we are delivering that person-centered care to people. So quite very impressive, quite key learnings there from Yock. And then in Wakefield, again, it was very clear that there was an appreciation, so despite there being some differences, but there was a common understanding of the strengths and weakness of each model, which again, I think that acknowledging the strength and the weakness is quite very powerful, because then it helps us to streamline things and then have an integrated offer to people that we serve. And they were quite innovative in their thinking and understanding that, you know, we need to embrace new ways of thinking and working. And I think this is quite very powerful, specifically within the NHS and also within the VCSE sector, because especially post-COVID, the sort of needs that people have that are quite complex, and also the way that we are now having to work, you know, the traditional way of thinking or doing things is not going to be fit for purpose. So I think it's a good thing that Wakefield already realizes that, and there's a willingness to embrace that thinking, you know, innovative way of working, which then enabled them to then see the strengths and the weaknesses of each model in the first place. They did appreciate that there are various models that are delivering to certain elements that adds to person-centered care delivery, and therefore no single model could own this. And again, it fits into the point that people do live complex lives and they need complex solutions, and silo thinking or being very precious is not going to deliver to person-centered care. And it then means that you won't have a holistic offer, because your model is going to get stuck if you're not actually able to move the person on, because people's needs and the way we live our lives is a continuum. So there's something there about recognizing that there is a continuum of person-centered care, and it's been very clear about what each model and where each area fits. Again, the enablers of that collaborative working was the fact that had effective leadership. So they had Anna there, you know, that was that's very passionate and keen to make sure that this is something that is happening and there's able to have collaborative working. There were issues around having to use different systems. Again, sometimes the contractual models and the things that we need to deliver to does not effectively support integrated systems and tools and processes. So it then means that we get stuck with those tools and processes and then moving away from the person-centered care. So I think that there is something there about, if we have a forum where we're bringing people together and being able to reflect on the practice, it enables us to then deliver, to then streamline, look at where there are crossovers and overlap. And certainly what the participants said would improve collaborative working. And an interesting point as well was the suggestion that, you know, we should reframe competition and duplication, because it could be a healthy thing. It's about offering choice, offering patient choice, offering clients the choice, and that by having healthy duplication and competition, it might actually result in better options and enable people to then have to collaborate. There were things around some services that are delivering similar, maybe link worker model, or just going under the umbrella of social prescribing when maybe it's not actually delivering all of that. So I think there's something in terms of, you know, there are various continuum of person-centered care and the way we deliver care that supports people, and people should not feel being put under pressure that all the services need to be tagged social prescribing in order to get funding, but actually recognizing that that could actually be healthy and is about having an integrated person-centered approach to delivering support to people and ensuring that we're not increasing inequalities, because some people can be accessing support via the GP practice. So those that are maybe homeless or not registered with GP practice, you know, they're likely to be more supported by a community-based link worker. And that is quite very evident with the times that we are in now with the COVID vaccination. We are literally going all out. Somebody was telling me about a homelessness shelter where they went to do a vaccination, where nobody's asking whether you're registered a GP, because you're not going to be able to vaccinate a lot of people if you're just going to concentrate on those that are registered as GP. So there's something about place-based support and care closer to home there, and recognizing the value that each organization or each service brings. So from those two reports, these are the recommendations from the reports and from the views of the participants. We need a strong leadership that actually supports person-centered working and collaboration across organizations and sectors. And I suppose that commissioners need to also enable this as well. Some of the recommendation as well included exploring and addressing any leadership, management, or culture-based barriers to person-centered working and collaboration. There's one thing about, saying we're doing person-centered care collaboration, but again, there might be some barriers at an organizational level that hinders that from happening. So scoping all link worker and connector activity in the area, looking across sectors and organizations. And like I said at the beginning, this is a movement and something that everybody owns, and it should not be about neither nor. This is about complementing and making sure it's then strengthened so that we have an integrated, personalized offer. And I think this is also even more important now, where we actually have other personalized care roles. That is not just the community and the connector roles. We've actually got other personalized care roles. So it is now very important that we are making sure we are mapping that and developing an integrated, personalized offer for our population. Again, it's for us to review and address any perception of lack of collaboration and confusion, reframe competition and duplication. So I just think that should not be the barrier or what has been at the forefront. So like I said today, Social Prescribing Day is trending for a reason, because everybody owns it and everybody is participating. So let's then work across those barriers or challenges, rather than putting up a block by, decommission my service, commission your service, for that being what is driving the narrative, rather than looking at the person-centered care and the strengths of each model and how they can complement each other to make sure that people do have choice. Again, ensuring that there is a mechanism for people to communicate in the first place. Again, this is my thing as well with primary care networks and other areas where people don't even have time to breathe. It's just go, go, go. You need to, how are you going to design, how are you going to know what you're doing? There's also quality improvement issues here if we're not going to validate that having time to sit and discuss and reflect on your practice is a good thing to do. So that's a recommendation, that there is issues around patient safety, if we're not even doing that in the first place. Again, we should be looking to review the opportunities to have integrated systems and tools and processes and questionnaires. Again, this also feeds into the agenda where we're wanting to empower people to be able to have access to what's going on with them and not having to repeat themselves over and over again. So there are issues there about continuity of care, if that is the goal of what we're trying to achieve. Then we should be looking at this similar and complementary models speaking to one another so that we can have an informed decision and make better decisions on the person's medical and clinical outcomes. Another thing also, again, is the funding. It's not just about funding, it's about ensuring that the funding is used well in the first place. So looking at just both the link workers and the connector models and just making sure that their funding is used well. And one of the ways to ensure that is actually coming together and appreciating the strengths and weaknesses of each of the models and how they might contribute. And then of course, nothing happens without capacity building. So the social prescribing link workers are helping build capacity with the person and at an individual level, but there is also capacity building at a community level. And what we're finding and what some of the participants says was funding for the activity-based element of it. So it's just not balanced if there's no funding for the activity-based elements of it, because we're not building capacity within the community, and that is where the support can be sustainable. So we are recommending that, you know, social prescribing link workers or social prescribing programs have a devolved budget to support community capacity building. Some areas are doing this. This is not anything new, and I'm sure that Anna will have some things to share in terms of how they've been able to support capacity building and the grants and the resources to doing that as well. And this is crucially important, especially if we are to address health inequalities, because there are some areas where there's nothing available. And what do you then expect the connector, the link worker models to do? Not being able to harness the assets that the people have got, to maximize that, to make sure that people are able to contribute to society.